So this is a continuation of the previous video. So we have chorea. The choreiform movements affect particularly the head, causing characteristic darting movements of the tongue and upper limbs. Okay, that is chorea. There's often emotional lability which is associated or obsessive compulsive traits which may last longer than the choreiform movements, which usually resolve within 6 weeks but sometimes may take up to 6 months. So that was about chorea. Okay, the choreiform movements particularly affect the head, darting movements of the tongue. It's called jack in that box tongue. Okay, there is often associated emotional lability and obsessive compulsive traits. So usually the choreiform movements will resolve between somewhere between 6 weeks and 6 months. We are looking at a time frame of up to 6 months as well. Erythema marginatum. It is a transient pink ring-shaped macule on the trunk and the inner surface of the limbs. So evanescent, that is transient. It is found primarily on the extensor surfaces. The rings are barely raised and are non-pruritic. The face is generally spared. So that was about erythema marginatum. Erythema marginatum occurs in the extensor surfaces. They are saying it occurs in the trunk and also the inner surface of the limbs. Okay, so it's going to be kind of like in the flexor aspect of the limbs. Transient pink ring-shaped macule. They are non-pruritic, meaning they are not itchy. They are just pink in color, and then they are macule, means they are not raised. Okay. Subcutaneous nodules. They are small, pea-sized nodules, non-tender, and are mainly found on the extensor side of the bony prominence. Particularly, they are seen on the hand, feet, elbows, occiput. Well, the ma'am said something about the occiput and like the spinous process of the vertebra, and yeah, that's the only thing I remember. And then, so about the subcutaneous nodules, they are not painful because it's not basically, there's no infection here, okay? The pathogenesis, there's no infection like in the immediate pathogenesis, so no pain. And then they are just nodules which are present on the side of the bony prominence, subcutaneous nodules. Moving on to the evidence of preceding group A streptococcal infection. With the exception of chorea and low-grade carditis, so both the C's are exceptions, both of which may manifest many months later. Evidence of a preceding group A streptococcal infection is essential in making the diagnosis of ARF, as most cases do not have a positive throat swab culture or a positive rapid antigen test. Serologic evidence is usually necessary. The most common serologic tests are ASO, that is anti-streptolysin O, anti-DNase B titers. Okay, so ASO titer and anti-DNase B titer. Okay, so they have to be the most common serological tests which are used. Okay. So we are moving on to the pathology here. Hallmark is going to be a patch called the McCallum's patch, and the most patients have may have Ashkoff nodule, which has Anishkov myocyte. Important points: pathology of rheumatic fever, Ashkoff nodules, McCallum patch, fibrinous pericarditis. How about the management? We're going to give them benzyl penicillin 0.6 to 1.2 grams IM stat, then penicillin V 250 mg per hour orally. Okay, so benzyl penicillin and penicillin V is used. Analgesic for carditis or arthritis, aspirin 100 mg per kg per day in divided doses. For 6 weeks, toxicity causes tinnitus, hyperventilation, and metabolic acidosis. And then steroids are specifically used if carditis is there with or without congestive heart failure. Valproate, carbamazepine for the chorea. Secondary prophylaxis, American Heart Association recommendations for duration of secondary prophylaxis. Category of patient and duration of prophylaxis. For the person who have rheumatic fever without carditis for 5 years after the last attack or 21 years of age, whichever is longer. For RF with carditis but no residual valvular disease, 10 years from the after the last attack or 21 years of age, whichever is longer. RF with persistent valvular disease, evident either, okay, this is important, evident either in echocardiography or clinically. We have to give it for 10 years after the last attack or 40 years of age, whichever is longer. Sometimes lifelong prophylaxis needed in these patients. Surgical replacement of the mitral aortic valve during the ARF results in rapid control of the congestive heart failure and decrease in the heart size despite investigational evidence for ongoing acute rheumatic fever. The surgical findings that indicate that it is acute hemodynamic overload secondary to valvular regurgitation which is responsible morbidity mortality. Other conditions, pandas and post-streptococcus